G'day team, and welcome back to Overheard in the Emergency Room. I'm Dr Cois, emergency physician, evidence nerd, and your guide through the messy, fascinating world of medicine. Today is something a little different. We're kicking off a new bonus series I'm calling Quick Hits. These are going to be short, punchy episodes where I answer the questions you've been sending in. No 45-minute deep dives, no 4-pillar evidence frameworks, just me, a microphone, and the practical answers you've actually asked for. You send in the questions, and I'm going to be picking them off one by one. And the very first question that came up over and over was this one. Dr. Cois, what actually happens when I walk into the emergency department with chest pain? What are you guys thinking? What are you guys doing? And why does it take so long? This is a great question, so let's answer it. But before we dive in, if you find this useful, please like, subscribe, and hit the notification bell so you never miss one of these quick hits or our other longer form episodes. And for free evidence-based health resources, head over to my website, drcois.com. That's where you'll find all of the companion content for everything we do. All right, let's get into it. So why do we take chest pain so seriously? And here's your headline. Cardiovascular disease is the #1 killer of people in high-income countries. That's America, Australia, and most of the developed world. So when someone walks through our doors clutching their chest, every alarm bell in our brains, and often the department, quite literally, goes off. The diagnosis we're most worried about missing is a heart attack, and the metric we live and die by is something called door to the balloon time. That's a time from when you walk through the ED doors to when an interventional cardiologist has a stent across the blocked artery in your heart, restoring blood flow. And the faster that we do that, the more heart muscle we save. And honestly, this is one of the great success stories of modern medicine. Cardiovascular disease mortality has dropped meaningfully over the last few decades. Not because of an influencer yelling at vegetables in a grocery store, but because of better recognition, faster symptoms, and tighter teamwork. So if you're sitting in our waiting room thinking, now, why did that person go in ahead of me? That's why. Now, let's talk about the 3 body systems that we worry about. When you tell me you have chest pain, I'm thinking about 3 main body systems: the heart, the lungs, and the gastrointestinal tract. And there's a 4th bucket that I'm going to call diagnoses of exclusion. I'll get into those at the end. But for now, let's go system by system. Starting with the heart. The top of this list is the myocardial infarction, or a heart attack. This is what happens when a cholesterol plaque that's been quietly building inside one of your coronary arteries for decades suddenly ruptures. A clot forms, blood flow stops, and the heart muscle downstream from that blockage starts to die. The first thing that we're going to do is an ECG. That's where we put the 12 sticky stickers, and the electrical tracing of your heart's cardiac activity comes up on the piece of paper. From the pattern that we see, we can often tell which artery is blocked. If we see a specific pattern called a STEMI, you are going to go straight to the cath lab. If we were playing Monopoly, I'd say something like, do not pass go, do not collect $200. At the same time, we'll also draw some blood. We'll be looking for a protein in your blood called troponin. This leaks out into your blood when the heart muscle is damaged. And many of us, emergency physicians, will do a bedside echocardiogram. That's an ultrasound of the heart. And we'll often do that right there in the resus bay. We'll be checking to see how well the heart is squeezing, if there are any regional wall motion abnormalities, and we'll be looking for other things like fluid around the heart, which can suggest a condition called pericarditis, which is usually a post-viral inflammation that we treat with anti-inflammatories. So the next system is the lungs, and there's 3 big diagnoses that we're looking for here. The first is pneumonia, and that's an acute infection of the lungs. Usually it's caused by a bacteria or a virus, and we often diagnose it with a chest x-ray and some blood work, but we don't need to. If we hear the telltale signs on examination, we can make the diagnosis. The next is a pneumothorax, and this is where air is trapped between your lung and your chest wall, which essentially deflates the lung. This one is treated with my personal favorite emergency department procedure, a chest tube. And yes, it's exactly what it sounds like, a garden hose sitting in your chest. And yes, we will numb you up first and we'll give you pain relief medication. And next is the sneaky one, the pulmonary embolism. It's a blood clot that usually travels from a vein in the leg up through the heart and lodges itself in the arteries of the lungs. It can cause chest pain, shortness of breath, low oxygen, and in the worst case scenario, a cardiac arrest. The gold standard to evaluate this is a CT angiogram of the chest, but it carries a meaningful dose of radiation, so we don't just shotgun this procedure and this investigation. Instead, we will often ask you questions about your risk. Are you taking an estrogen-containing medication? Have you had a recent long-haul travel? Have you had recent surgery? Do you have active cancer? And do you have a personal history of blood clots? We use those questions to decide who genuinely needs a scan and who doesn't. The next system is the gastrointestinal tract. The most common GI cause of chest pain is reflux. That's stomach acid creeping up the esophagus. Classically, people will present with burning behind the breastbone that's made worse when they're laying down. It's annoying, but it's not dangerous. There are two scary GI causes of chest pain. That is esophageal rupture, where you have a tear in the mucosa of the food pipe, and this is as bad as it sounds, and a perforated peptic ulcer, where an ulcer in the stomach or the duodenum erodes all the way through into the wall. Both need imaging, antibiotics, and likely surgery. Both are why we sometimes get a CT scan even when your heart looks fine. Now, let's talk about the honorable mentions. There are a few extra diagnoses that are worth a quick name drop here because your ED doctor absolutely is thinking about them even if they don't mention them out loud to you. The first is an aortic dissection. This is a tear in the lining of the aorta, the big blood vessel coming off the heart. Classically, people will present with severe tearing chest pain that radiates to the back. It's diagnosed also with a CT angiogram. If you have this, you go straight to cardiothoracic surgery. Spontaneous coronary artery dissection. This is a heart attack mimic that disproportionately affects young women. Myocarditis. This is inflammation of the heart muscle. Most often it is post-viral. Esophageal spasm. Exactly what it sounds like and can be very, very painful. And then the one you'll most often go home with, a musculoskeletal strain. Those tiny muscles between your ribs, they have to work 12 times a minute, every day. When they get strained, they can take a little while to settle down because you can't exactly stop breathing while they heal. I'll be honest with you. When I diagnose someone with musculoskeletal chest pain or gastritis in the emergency department, I always hedge because these are essentially diagnoses of exclusion. What I'm really saying to you when I give you this diagnosis is that I've ruled out all the things that will kill you tonight. The rest needs to be followed up with your primary doctor. Which brings me to the most important point of this whole episode. If you take one thing away from this quick hit, take this. If you have chest pain that's new, severe, or doesn't fit a pattern you recognize, come in. Don't Google it, don't wait it out, don't text your cousin who is a nurse, come in. We would much rather see you run the workup and send you home reassured than meet you in 3 hours with a cardiac arrest. And once you've been cleared, that doesn't mean the work is over. Because the chest pain that brought you into the emergency department today is often a signal. Sometimes it's a literal warning shot that the foundations of health need attention. Things like blood pressure, cholesterol, sleep, stress management, and exercise need some work. It's the tier 1 stuff that we talk about on this show every single week. And that's the whole point of Overheard in the emergency room. I see the end stage version of years of neglected foundations, and I truly want you to never need to see me or one of my colleagues. And that's it for our very first quick hit bonus episode. Short, sharp, and hopefully really useful. If you've got a question you want me to tackle next, something you've always wondered about in the ED, a symptom you don't understand, a health topic that's been bugging you, drop it in the comments. Send it through the website or DM me on socials. I'm building this series around what you want to know. If this episode helped, please like, subscribe, and hit the notification bell so you never miss a quick hit or a full episode. Share it with that family member who keeps Googling their symptoms at 2 a.m. You know the one. And for the companion blog posts, references, and all my free resources, head to drcois.com. I'm Dr. Cois. Let's chase fewer bad days and more good decades together. We'll see you next time, but hopefully not in my emergency department.